So, question for you would be, if you have low and intermediate risk, you feel not concerned if you offer an ablative treatment. Because if you would have, let's say, just treating one lobe and you would have recurrence in the other one, I would expect it's again low or intermediate risk. But if you treat a high-risk tumor in one lobe and you would let the other unaffected, are you not concerned that in the other lobe develops again a high-risk tumor in due time?
I think that's a concern. We just don't have any data to show whether that is a real concern. So in our 625 men now with median 5 years follow-up, 2% had out-of-field de novo or progressive disease. So that's a couple of handfuls, maybe 3 handfuls of cases where new tumors were found in areas outside of the original treatment. I suspect most of those are probably MRI missed or template mapping biopsy missed. I think one case was very high grade, and that is probably a truly progressive disease. I think the majority of that 2 to 3% that we saw on follow-up, and I expect it to be higher, I expect it to be around 5 to 10% by 10 years, is probably staging error from the original MRI and the original biopsy. Whether we see a higher progressive rate from new cancers emerging, I don't know. We'll see.
Just a question. Ash, very nice presentation. When we shift to high-risk disease, it's always the same question. I think we need to consider also how we manage the local regional disease, how we manage the lymph nodes, and I would like to have your point of view how that should be best done. So
I had an email today from somebody who said on the West Coast, a very prominent urologist did focal therapy in a high-risk man and then did a robotic lymphadenectomy. And it's an N=1. I think people are increasingly interested in that because you have the benefits of focal therapy for the prostate, which is good functional outcome, whilst assuaging the issues around pelvic control. So I don't know. I think we have to do a study in that to show whether that's legitimate.
Do you really think that it's an option to go for focal therapy and then afterwards for a lymph node dissection, a surgical lymph node dissection?
I find it a bit strange, but you know, what's interesting is that as innovators, which we all are here, I'm going to keep an open mind. There may be a population of men who want to avoid, who have a tiny discrete lesion. It's high risk. Everybody agrees it's high risk. You want to make sure that the lymph nodes are being controlled, but actually he's very worried about ED and incontinence and all of those things. So there may be a discrete group, and I don't think I, as somebody who generally likes to keep an open mind, would want to close my mind to that. I find it a little odd that you wouldn't want to just take the prostate out at the same time. But, you know, it might be a legitimate strategy. I mean, you know, the urologist who does it, I have a huge amount of respect for on the West Coast. So I think you can probably work out who he is. And you know, in his mind, that seemed to make sense. But we'll see.
And in your small series you just presented, how did you manage them? Did you rely on sophisticated pre-treatment staging exams?
Yeah, so most of our high-risk cases got choline PETs.
Colon, okay.
And bone scans, so that might help.
Ash, just a question. We have discussed this before, and when you look back at the radiotherapy data, they combined radiotherapy with hormones and ended up working better than radiotherapy alone. For the high-risk population, perhaps we could eventually do a symbiotic treatment, the focal treatment plus hormones or something else. What's your opinion about it?
Yeah, no, I think I think it's the next question that we have to ask. You know, at the moment we're getting 20 to 30% redo HIFU or 10 to 20% redo cryo rates. Can we reduce that and still maintain the functional benefits? And radiotherapy, the vast majority of radiotherapy studies until PROTECT came out were based on radiotherapy versus radiotherapy with something else.
Right.
or radiotherapy plus a bit of hormones versus radiotherapy plus a bit more hormones. And you know, you can deliver randomized controlled trials, level 1 evidence, and you get into the guidance because you've proven that radiotherapy with a bit more is better than radiotherapy on its own. And I suspect that is probably going to be the only way we're going to deliver randomized controlled trials with focal therapy, but it does have a scientific rationale behind it, just like it did with radiotherapy.
I think for radiation therapy, it makes sense, really, the association of hormones, because this is kind of symbiotic effect of making much more effective radiation therapy when receiving hormones. And this is not the case for focal therapy. This is not.
You might be able to, by cytoreduction, get rid of the heat sink. So if you think the heat sink is an issue, devascularizing the tumor might have a scientific rationale.
I could understand that in reducing the size, and that will be very short-term hormone therapy. I mean, probably 3 months.
Yeah, neoadjuvant.
Like this. Otherwise, we should be considered like focal therapy plus hormone as a combination therapy. It means that this is far away from minimally invasive treatment. That this is the main issue behind focal therapy.
I understand that the rationale, besides what Ash just mentioned, is that there's studies on the treatment of deployment of hormonal therapy, like the one-shot study from Olivier Cousneau in Paris, in which you could eventually be knocking down those satellite lesions, that they're indolent lesions, and they will eventually respond better to the microenvironment impact of heat or cold. So definitely this is just hypothesis, but perhaps in the future we could look at that.
There are other things like vaccines. You know, there is some evidence that HIFU and cryo has a very low subclinical immunotherapeutic potentiation. It boosts some kind, and by giving a vaccine before and just after, can you boost that immunotherapeutic effect? And that might be another neoadjuvant and adjuvant strategy, which makes scientific sense.
We saw in Barcelona too, in ISO, robotic partial prostatectomy performed by Arnaud Villiers, and that's another kind of focal therapy if you want. But
that's when I knew. That's when I knew we won the argument.
Yeah.
When the robotic surgeon started to do partial, that's when I knew that focal therapy as a concept was here to stay.
Have been doing during the colorectal surgery, have been doing partial prostatectomies for years.
That's true.
Okay. Any more questions? Thank you very much.
Thank you.
We go to the next.